Hey everyone, thanks for being here again. I just went through and looked at YouTube and I can't believe that so many of you have watched this channel. And thank you, first of all. Second of all, for today, as I was thinking about all the different things that a thyroid surgeon like me could help you, a person who has a thyroid problem with, it seemed like one of the best things that I could do would be to take all of our really good guidelines and break them down to a level that you understand. And so for today, I'm going to take the 2025 American Thyroid Association guidelines and go through all 150 pages in a pretty efficient fashion and go through each of the different topics. I'll review them and then I'll go into a little bit of depth about how it applies to me and to my patients. I'm Jon Russell. I'm a thyroid surgeon. I work at the Russell Center for Endocrine Health, which I founded after working at Johns Hopkins and the Cleveland Clinic for about 15 years combined. I was the director of the Thyroid Cancer Tumor Center at Johns Hopkins, and now we've set up our own concierge-like practice near Washington, D.C., where we help patients with the most complicated thyroid and parathyroid problems. We offer all of our patients minimally invasive options, and the American Thyroid Association guidelines actually talks about those options as well. I'm also a member of the American Thyroid Association, and specifically, I'm part of the Guidelines and Statements Task Force. And so our job is to make sure that the guidelines and statements that come out of the American Thyroid Association represent the best ideas and science that are available for you as you go forward and treat your thyroid cancer or other thyroid problem. So without further ado, I introduce to you the 2025 American Thyroid Association Management Guidelines for Adult Patients with Differentiated Thyroid Cancer. This was written by Dr. Ringel and Dr. Sosa, who were two of the lead authors on this massive project that took years and years to get finished. These guidelines, just to give you a background, these take years. They take hundreds, if not thousands of hours. This is all free labor that is put forward by doctors, physicians, scientists, people who care about you and want to make sure that we know the best way to treat you. The people who were involved in this are almost all of them really good friends of mine. And this is just absolutely fantastic work. To give you background on it a little bit deeper, differentiated thyroid cancer means papillary or follicular thyroid cancer. Hürthle cell is sometimes lumped into there and sometimes medullary. But for today, for the purposes of today's conversation, we're going to focus on papillary and follicular. Together, they make up between 90 and 95% of all thyroid cancers. And these are the ones that if you hear that a friend had thyroid cancer or if you have thyroid cancer, you almost certainly have one of these two types of thyroid cancer. They have a really good prognosis, and that's what drove these guidelines. We don't want to be over-treating patients, but at the same time, it's really almost just not acceptable that one of our patients should have a bad outcome when they have one of these cancers. Let's dig in further. Now, one other noteworthy thing about these guidelines, Gary Bloom is actually the person who founded THICA, which you probably know as the Thyroid Cancer Survivors Group. And Gary's also a friend of mine. This is the first set of guidelines that actually asked patients what they thought about these treatment options. And so these are really unique guidelines, even looking at other guidelines around the world that doctors come up with. We wanted patients' input. Thyroid cancer survivors make up one of the largest groups of cancer survivors in the world because patients with thyroid cancer do well in general. They don't tend to die from thyroid cancer. And so there's a lot of patients alive who have had this and have been treated and have insights. And those insights made it into this set of guidelines. In the United States, there are going to be approximately 45,000 new cases of differentiated thyroid cancer every single year. These guidelines have gone through multiple iterations over the years. They first came out in 1996, and then they've been updated every 10 years plus or minus. The last time that these guidelines were updated was in 2015. Which incidentally is about the time that I finished my training and focused my entire career on thyroid and parathyroid surgery. So this is great because over the course of my career, we've seen a lot of things come up. In fact, when I started my career, there were no such things as options like radiofrequency ablation. Remote access surgery was super minimal, wasn't even really involved. Now all of these are big things that we talk about all the time. Molecular markers, also super important. Active surveillance has only grown and become more popular since then as well. All of these things are included in this latest update of the guidelines. So one of the things that they focus on with this guidelines, and they really start off the guidelines with this, is this idea of data. So first you start with the diagnosis, that's the D, then you assess the nodule and the risk and the benefit of the various different options, and then treatment or active surveillance, and then assessment again. And so as you're going through this, you diagnose, you assess, you treat, you assess, And you go through and you constantly evaluate whether or not somebody needs to escalate their therapy or do more, or if they can de-escalate and do less. And by doing this, we hope that we're going to give each of our patients the best possible outcome. Now, the other thing that if you have a copy of these guidelines in front of you, you're going to want to look at the different tables that show the risk associated with the different types of thyroid cancer. And in these guidelines, it breaks it down into the 3 different types. So there's papillary, follicular, and then oncocytic, which used to be called Hürthle cell. And with each one of these, there are different risk factors that when you look at them, you will know as you're going through your data algorithm that we just talked about, you'll know which factors are more likely to end up as higher risk nodules, and therefore which ones need to be treated more aggressively. Now, the first recommendation has to do with something called NIFT-P. So NIFT-P is what we used to consider a very low risk or very not aggressive thyroid cancer. And both NIFT-P and tumors of uncertain malignant potential or follicular tumors of uncertain malignant potential are classified as almost precancers. And as such, they do not need more aggressive therapies such as a completion thyroidectomy or anything else. However, the difference between this and other things that we can just diagnose with a simple needle biopsy, you do need to diagnose these with surgery, because for most of these precancerous tumors, you're not going to be able to get enough information without doing surgery so that you can look at the entire nodule. And that's because the cells under a microscope will look essentially identical to non-cancerous cells. So non-cancerous, cancerous, precancerous, they can all look the same for this follicular type of tumor. The second recommendation that they talk about is when you should do germline molecular testing. So germline testing means that you're looking for a problem in the DNA of all of the cells of somebody's body, i.e. a problem that was inherited. And so there's a few situations in which you should check somebody for inherited cancer syndromes. Those include if you have like a P10 or a Cowden syndrome, if you've got familial non-medullary thyroid carcinoma, which is at least a couple of first or second degree relatives who have papillary thyroid carcinoma, or if you have a Dicer tumor mutation, you also should be looking at molecular testing, genetic germline molecular testing, if you have cribriform morular thyroid carcinoma, or if you have others such as Carney complex or Werner's syndrome. These are a few different conditions in which case you might want to do that. Patients always ask, do I need to check all of my DNA? Do I need to check my family? Unless you have one of those conditions, or unless your specific doctor thinks you should, you probably don't need to do that. That's a good time for me to pause. With all of what I'm going to go over, these are recommendations from some of the most intelligent, most dedicated doctors in our field. However, your specific case needs to be discussed with your specific doctor. If I can help, please give me a call. But otherwise, these are guidelines to work from, not the gospel for you. Recommendation 3, again, going back to genetic testing and whether or not you need to have that done if you have certain types of thyroid cancer that cluster together as families. Usually we don't recommend that. We don't have enough evidence to say whether or not it's going to happen. Recommendation 4 says, however, if you do have 3 first or second first degree relatives with a follicular or a well-differentiated thyroid cancer, so follicular or papillary or Hürthle cell, if you have 3 first or second degree relatives, then you should start by screening with an ultrasound, because an ultrasound is going to give you the most information. And then number 5 just kind of focuses on the fact that when you have testing of your cancer, so of the nodule itself, if it finds a specific mutation that might be associated with a familial condition, you should evaluate the person for that familial condition as well. And so the tumor mutation can be different from the person mutation, and doctors need to be cognizant of that as they're talking. Number 6 is a guideline that really hits close to home for me, and that's the recommendation that you need to be having surgery with somebody who does at least 25 to 50 thyroid surgeries every year. Most of us who are really dedicated to thyroid surgery do hundreds of thyroid surgeries every single year. But you need to, as you're trying to get your loved ones taken care of, make sure that you see somebody who does at least 25. No matter where you live, that's kind of the minimal bar for what you should be looking for. It's interesting, when you compare the outcomes data, the outcomes are so much better if you find a high volume surgeon. What they also looked at was whether it's the hospital that matters or it's the surgeon that matters. And notably, the hospital where you have it done, if the hospital does lots of surgery, it will be cheaper. But If the surgeon does lots of surgery, you will have better outcomes and lower complications. Recommendation 7 is important as we talk about somebody that we know has thyroid cancer. We want to be looking at all of the different parts of the neck to see if they have lymph nodes. We do that with an ultrasound. If there are lymph nodes that are suspicious, we should do a biopsy. And if we do a biopsy, adding thyroglobulin to the needle washout makes it more likely that you're going to get a positive, or rather a diagnostic answer. In other words, when you have thyroid cancer, or we think you have thyroid cancer, you need to have something called lymph node mapping. That's why I do my own ultrasound on every single patient that I see, but it's also why a lot of doctors send patients out to somebody else to look at their lymph nodes to see if there's any cancer outside of the thyroid. And then if there is, and it's relatively large, you should do a biopsy. But you don't always need to biopsy small things that are kind of indeterminate. This gets into a lot of the nuance, really into the weeds, and you'll need to talk to your doctor closely. But this is something that's super important for you to understand as you're going through considering how to manage your thyroid cancer. Recommendation 8 is something that I talk to patients about all the time. Everybody thinks that when you have thyroid cancer that maybe you should have a CAT scan or a PET scan. And the American Thyroid Association guidelines highlight that that's actually not what you need to do. Most patients just need an ultrasound. If we are worried because your cancer looks especially aggressive, then a CAT scan might be appropriate. But in almost no cases would a PET scan be required at the very beginning of your treatment for thyroid cancer. So you don't need one in most cases. For me, as a surgeon, that's actually one of the clues that I look for to figure out whether or not another surgeon or another doctor treats very much thyroid cancer. If they sent you for a PET scan, I kind of know that they usually don't treat very many people with thyroid cancer. Number 9 and 10 continue talking about what we do before surgery. First of all, with number 9, we don't need to get specific labs like thyroglobulin, although that is a lab that can help us after your surgery. And the reason for that is it doesn't provide a lot of utility. And so we try not to order tests that aren't going to help us. The same thing goes for doing further evaluations of your cancer before surgery. In most cases, we don't need to send you for advanced molecular testing because we know that surgery is the mainstay of therapy for most thyroid cancer. Now, in recommendation, we really start to get interesting because we talk about active surveillance. Active surveillance means that we're watching a cancer instead of taking it out right away. This is relatively new. It's based on a large body of data from Japanese patients who, over about a 20-year period, only a very small percentage of their small cancers progressed to need further surgery or treatment. And so because of that, if you have a cancer that is smaller than 1 centimeter, first of all, in the United States, we don't recommend that you have a biopsy. But second of all, if you do have a biopsy and we find it and it's that small, one of the first things that you should be offered is active surveillance, meaning you don't always have to rush into surgery. Some patients may choose to have surgery, and that's because it feels good to get rid of a cancer, but your doctor should probably discuss with you the pros and cons of surgery versus active surveillance. In some situations where you are considering active surveillance, and this is something that I feel like I've been able to contribute to quite a bit in our field, is you can consider radiofrequency ablation or other ablative therapies to try and kill these small cancers. In other words, you don't have to have surgery, but we can still sometimes kill the cancer with another therapy, usually a percutaneous or through your skin needle-based therapy. These can be very effective for these small tumors, and in some cases, we can make them disappear on future ultrasounds. There's lots of different options. There's microwave, there's radiofrequency ablation, there's even newer things such as nanopulse, maybe even histotripsy. All of these things are coming down the line. The best one for you is going to be the best one that your doctor does and feels the most comfortable with. Most of the data seems to suggest that the people who get the best outcomes will use radiofrequency ablation. They have the highest disappearance rate and the best safety profile. Number 13 talks about thyroglobulin. Again, if you're not having your thyroid taken out, you usually don't need to have your thyroglobulin checked. For patients who choose to have active surveillance, number 14 gives us guidance about when you should stop doing active surveillance and start doing surgery. That should happen when your tumor grows by 3 millimeters, so about 1/3 of a centimeter, which is each centimeter is about 1/2 of an inch. So that gives you an idea. It's not very much growth, but if your cancer is growing, you should probably have surgery before it becomes more aggressive. Likewise, if we see that your cancer is spreading to another part of your body, you should also have surgery right away. These are things that can help us to keep you safe if you choose to move forward with active surveillance. Number 15 is interesting because if you're going to a low volume surgeon, you're probably not going to hear this information. But for small cancers, smaller than or up to 2 centimeters, we usually recommend starting with only a lobectomy. That means taking out half of your thyroid. We do it because it's not only safer, but it's also usually adequate for what you might need for your thyroid cancer. For patients with tumors between 2 and 4 centimeters, those are the patients who could either have half of their thyroid taken out or their whole thyroid taken out. There's pros and cons, and it's based primarily on whether or not we think you're going to need radioactive iodine afterwards. More on that later. If you've got a tumor that's bigger than 4 centimeters, a cancer that's bigger than 4 centimeters, I should say, or if we know that you're going to need radioactive iodine because of distant metastases or local metastases or some other sign that your cancer is more aggressive, you probably want to be thinking about a total thyroidectomy. Number 16 talks about when we need to do more surgery. So if we take out only half of your thyroid and then on final pathology we see that it was a cancer that surprises us or it was more aggressive than we thought it was going to be, you can do a completion thyroidectomy to go in and take out the other side so that you can have radioactive iodine, or if we didn't take out everything the first time. Not taking out everything the first time, we don't really love that. And so we try really hard during the first surgery to make sure that we get it all, at least on each side. Number 17 is a kind of a unique situation. Your thyroid, when you're inside of your mom before you're born, your thyroid starts at your tongue and then it descends from your tongue down into the bottom of your neck. As it does that, it can leave behind little rests or cells of thyroid tissue. In rare cases, these can become cancer. One of the more common but still rare types of thyroid cancer that does this is something called thyroglossal duct carcinoma. And that's when you get something up high next to your hyoid bone that becomes a cancer. In that situation, you don't always have to take out your whole thyroid. Sometimes you can just take out the hyoid bone and do a complete cyst-joint procedure and take out the nodes close by this area. In other cases in which we think the cancer is more aggressive, you might have to take out your entire thyroid. As with thyroid cancer, if on the final pathology we find out that it was more aggressive than we thought it was, you might want to go back and take out the rest of your thyroid after that. Number 19 is also interesting, and it talks about a prophylactic central neck dissection. Some doctors at some pretty well-regarded centers from the United States will very proactively remove lymph nodes close by your thyroid. The American Thyroid Association generally discourages this, and the reason is that your complication rate will be significantly higher if you do it. Some of us, however, may sometimes take out more lymph nodes if we are worried about the patient, either based on our ultrasound, based on suspicion of nodes, or if it's going to change our management of how we take care of that patient in the future. Number 20 also talks about lymph node spread, and it kind of focuses on the idea that if you know that a patient has thyroid cancer that has started to spread in the lymph nodes, you should clear out all of the lymph nodes in any area that you go into. In other words, if the cancer is close by your thyroid, clear out the lymph nodes close by your thyroid. If the cancer is out in the side of your neck, clear out all of the lymph nodes in the side of your neck. Don't just do a spot surgery where we take out a couple of things. That will make your recurrence rate be much, much higher. That's one of the reasons that, just like with the volume of thyroid surgery, if you have metastatic lymph nodes, you need to ask how many neck dissections your surgeon does and has done. A lot of surgeons don't get very much training in how to do a neck dissection, and that might influence you about who you pick for your surgeon, because if you have cancer that has already started to spread, it's going to be super important to you to make sure that you get the right surgeon, so you only have to do this once. The better surgery you have up front, the less likely you are to need more surgery in the future. Number 21, recommendation number 21, talks about what your surgeon, should do before surgery and the risks that I should review. I should talk about the risk of nerve injury. I should talk about hypoparathyroidism, if I injure your parathyroid glands, and other relatively common complications that are focused on thyroid surgery. Number 22, also focused on your surgeon. Your surgeon should ask you about your voice before surgery, and in some cases, they should examine your voice with a camera down the nose. That allows them to know before surgery whether or not you have a problem. In our practice, we do this on all of our patients who are planning on having surgical treatment because it gives us more confidence about the nerve monitoring that we're going to be using to help keep you safe during surgery. Number 23 focuses on using a nerve monitor. Now, most patients who have surgery, they'll be asleep during surgery. The breathing tube actually can help us to know whether or not we have hurt your voice. We use a nerve monitoring tube. We stimulate your voice, and that should be done at certain time points. it can help you and your surgeon to avoid hurting the nerves on both sides. If that happens, the complication can be quite devastating. And so it's more guidelines to your doctor about how to do that correct. Your doctor in general should be finding the recurrent laryngeal nerve, examining it, and making sure that they protect it. They're more likely to get better outcomes when they do. Recommendation number 24 talks about how we protect your parathyroid glands. We should try to push them away from your thyroid so that we don't take them out at the same time. And if we notice that we hurt them, we should put them back in where they have a chance to grow back. Also, after surgery, we should use your labs to help guide us about whether or not you need calcium so that we can protect and get you out of the hospital sooner. Number 25 talks about drains. In the old days, surgeons used to use a drain after thyroid surgery. That is discouraged in this most recent version of the guidelines. I have published, other surgeons have published recommendations and observational studies stating that these drains usually don't help to keep patients safer. There might be exceptions, and if your doctor uses one, you can ask why. Recommendation 26 talks about your voice. After surgery, your surgeon should check in with you about your voice. If your voice is doing well, great, no issues. But if you're not doing well with your voice, your surgeon needs to figure out why. Was your nerve injured? Is your voice going to recover? Should you be referred to somebody who can help you be safe and recover faster? Usually that would be a speech pathologist who can help. Number 27 talks about the pathologist, and it gives best practice recommendations for pathologists to point out different things that could indicate your risk of recurrence and also risks that might happen to your family members. Pathologists shouldn't just say, yes, it was cancer with no other details. They should talk about vascular invasion, and they should talk about suspicious subtypes as well as lymph nodes, etc. Number 28 talks about how we risk stratify you after surgery. So in general, each surgeon after your surgery is going to look at your tumor and predict whether or not you are low or high risk for recurrence. It will include your pathology, it will include your labs, it will include a number of other factors as well. We don't necessarily need to send you for extra genetic testing. It's not usually going to provide value. But if you do get that genetic testing, we can also add that into your specific prognostic score. Now, when I say score, it's not likely that we're going to give you a percentage likelihood of recurrence. We're more likely to give you a range, low, high, or intermediate risk of recurrence. Recommendation 29 talks about your individual response to surgery and how that predicts your outcome. If your thyroid globulin is low and your ultrasound is negative, then your risk of recurrence is also low. Alternatively, if you have some thyroid globulin, maybe more than 1.5, but you don't have anything inside of your neck, you might have an indeterminate or a kind of borderline medium risk of recurrence. And if you have an elevated thyroid globulin and disease or evidence of things left behind or new nodes inside of your neck, we would be more concerned. That first evaluation should happen about 3 months after surgery. The 4 categories that we can consider are excellent response, in which case you have no evidence of any disease left behind. An indeterminate response where you have something non-specific, meaning we don't know for sure how your outcome was. A biochemical incomplete response where your neck looks good on ultrasound, but your thyroid globulin levels are still elevated. Or a structural incomplete response when we look inside of your neck and we can see that there's still actual tissue left behind or new nodes. Recommendation 30 says that we should check your thyroglobulin as a measure of how you've done after surgery. And we should usually check it about 6 to 12 weeks after surgery, which is when it's at the low point after removing your thyroid. It's okay to do that while you're taking thyroid hormone, and that will give us valuable information about your prognosis. Number 31 is pretty complicated because it involves all of your recovery process and really goes into detail. So here we go. Let's try and go through this. You should do an ultrasound first. That's the best way to check. But if your thyroid globulin levels are elevated, maybe above 1.5 again, for example, above the excellent threshold, then you should think about doing cross-sectional imaging, whether a CAT scan or an MRI, to see if there's any nodes that were missed or any disease left behind. Then 6 to 12 months after surgery, you should have another ultrasound to make sure that things are clean in the neck after you've had thyroid surgery. Any lymph nodes that are smaller than 8 to 10 millimeters, so smaller than a centimeter, don't need to have a biopsy. You should just keep watching them with future ultrasounds in most cases. If we're worried about a lymph node, it's okay to biopsy it, and you should include thyroid globulin in the needle washout. Then, if we can't find something on your ultrasound, but we see that your thyroid globulin is going up, usually we want to talk to you about cross-sectional imaging as well. And then finally, in rare cases where we've done all of these other tests and we still can't find anything, that might be the first time that we would start to talk to you about getting a PET scan to help you with your thyroid cancer. So thanks for checking in. We got down to number 32. So we covered the first 31 guidelines. Stay tuned, come back, check in for the next one where we'll go over and talk about radioactive iodine, when you need it, how it should be administered, and we'll keep going from there. Send me your comments, give me your ideas. We'll keep covering this topic and these guidelines. Super important stuff. Thanks for listening, and see you soon.